Dr. I just like to say what we have is a double filtration plasmapheresis. So it's more for plasmapheresis and not an adsorption therapy. Both of them are being supplied by Crown, and I think they have borrowed our machine to actually have a look at it. So it's just a filtration, a plasmapheresis machine that we have. Instead of throwing away the plasma, we can recycle it back to the patient. We used it recently on a GBS patient. So it's a bit different from the adsorption technology, but they're both being sold by Crown, and I'm not being paid to say so. So my name is Dr. Esajji. I'm a head of nephrology at Aga Khan Hospital, Mombasa. I'm talking about the citrate journey. Now, I was supposed to talk about citrate and heparin, but I've decided to label this talk as citrate journey because the citrate journey doesn't start by you, one person. It takes a whole team of people, and it's a journey. And I was fortunate to be under a mentor who believed in such therapies and actually introduced us to such therapists, Dr. Mongera, and colleagues who believed on the same thought, and nurses, ICU nurses, especially Nurse Mirigi, who actually was the champion at the Nairobi hospital. Previously, I worked at the Nairobi hospital, and that is where we did the first citrate anticoagulation in this country. So where does the problem come from? The problem comes from the fact that we have critically ill patients, and they all have thrombocytopenia. So this was a paper done at Mayo Clinic Hospital. And what they found was that thrombocytopenia was already present at admission in around 25% of the patient, and around 22% of the patient developed thrombocytopenia within the hospital stay during the ICU stay. So we have patients who require dialysis, who require continuous renal replacement, but they have a propensity to get thrombocytopenia. So that is where the problem lies. Now, if you look at this same study and you look at the thrombocytopenia and what was the effect of it, you find that major bleeding occurred in a larger percentage of patients who had thrombocytopenia versus those who did not have thrombocytopenia. Not only that, if you look at transfusion need, so most patients required transfusion who had thrombocytopenia versus those who did not have. The same happens for AKI. So if you had thrombocytopenia, you had a risk of developing AKI. We go on to look at studies that had looked at AKI in South Africa, and we see that AKI develops in around 58.5% of ICU patients. Now we know that AKI is going to be there, so we expect that we'll need some dialysis therapy. And we look at the patients who require dialysis. For you, it might be 88 patients from 497, that's not a lot, but each patient counts. And when we are deciding what do we offer them, we think about, do we offer them CRRT, do we offer them SLED, or do we offer them intermittent hemodialysis? So these are our choices of dialysis, and it actually depends on the patient's hemodynamics. Is the patient able to sustain an intermittent hemodialysis session, which is what we'd want? But most of our septic patients are not able to sustain such a therapy. And because of that, we have to give them longer dialysis sessions, such as continuous renal replacement therapy or slow, low efficient daily dialysis. Now, why are we talking about this? This is because the longer the treatment, the slower the speeds, and the slower the speed, then we have clotting becoming an issue. And we are always looking at circuit life. We are trying to save this patient of cost. We all know the continuous renal replacement therapy are quite expensive. We will never be able to afford them on a daily basis. At the same time, we want to make sure that that circuit that we have primed on is going to last us as long as possible. And these patients have a propensity to clot, not only because they are in a hypercoagulable state because of the sickness, but also other effects such as the procoagulant effect of the lines and the low blood flow rates. Remember, this is not an intermittent hemodialysis. We can't really move the blood very fast. Not only that, we have one nurse nursing this patient, and she's turning the patient, giving food to the patient, giving medication to the patient, monitoring the CRRT machine, monitoring the SLED machine. And so she's not going to respond appropriately to the alarms. And when the alarms are ringing, the blood flow is very little, or the pumps are almost not moving. At the same time, we want to try convection and ultrafiltration in these patients. And the more you remove, the more hemoconcentration you are causing, and the more hemoconcentration, the higher the risk of clotting. So we talk about anticoagulation. Do we go for the systemic anticoagulation that we have all been used to, such as heparin, or do we go for regional anticoagulation? And nowadays we are talking about regional anticoagulation. Most people are moving towards regional anticoagulation, such as citrate. So we are going to look at heparin and what is heparin, then discuss citrate. Now, studies have been done to see the circuit lifespan in each type of anticoagulation, citrate versus heparin. And from this, you can see that the citrate actually has a higher lifespan compared to the heparin. So this will help us save cost. A meta-analysis was also done, and they found that citrate versus heparin, there was a longer lifespan of the circuit, and there was less bleeding associated in these patients. So we all know heparin, we have all used heparin, and we know that heparin works as an anticoagulant by activating antithrombin, which then inactivates thrombin and factor 10A and other proteases. Now, the problem is, as I said before, thrombocytopenia in ICU. And thrombocytopenia in ICU is not just as a result of our therapy, but it's also as a result of the severity of illness requiring the continuous renal replacement therapy. It's also because of the medications that we have to use. We cannot do anything about it. Some other comorbid conditions that the patient might have. Patient might be requiring some aspirin, antiplatelet agents. And there's also loss through the hemofilter or consumption through the system. Now, there is associated higher events of thrombocytopenia in those patients who receive heparin versus those who receive other forms of anticoagulation. And we always have heparin-induced thrombocytopenia. Now, heparin-induced thrombocytopenia is rare, but it is a reality. We have type 1 and type 2. Type 1, we will say, is the non-immune mediated heparin-induced thrombocytopenia. In fact, it's better to call it associated rather than induced. And usually it occurs around 10 to 30%, and the thrombocytopenia is usually milder and rarely below 100,000. Now, type 2 is the immune mediated, and that is where the problem lies in heparin. And usually it develops 5 to 10 days after initiation of treatment, and it comes in with severe thrombocytopenia. It's rare. It occurs 0.5 to 5% of patients who are using unfractionated heparin. Now, the risk factor of heparin-induced thrombocytopenia depends on host-related. So we find that females have a higher risk compared to males, and the older you are, the higher the risk of developing HIT. The second thing is drug-related, whether you're using unfractionated heparin or you're using low molecular weight heparin, and then the duration of treatment. The pathophysiology comes from platelet-derived factor. Platelet-derived factor is supposed to help eliminate the heparin, but by binding to heparin, it now opens a Pandora box. And what happens is immunoglobulins are formed, which then start attacking, which bind to the surface of the platelets and cause activation of the platelets. This leads not only to a pro-thrombotic state, but also a thrombocytopenic state. Now, the management of heparin-induced thrombocytopenia is you stop heparin. The minute you stop heparin and use another form of anticoagulant, the antibodies will not be formed, and in that way, we will reduce the risk of thrombocytopenia. Now, there's always, even in my unit, where at the moment we don't have, in Aga Khan, we are not using citrate anticoagulation. We try to do regional anticoagulation by using the heparin protamine circuit. Protamine actually binds to the heparin and inactivates the heparin. However, we don't really have data about it and a comparison between heparin protamine versus citrate yet. Now, citrate anticoagulation. What are the patients that you choose for citrate anticoagulation? Although a lot of people are for using citrate anticoagulation in all CRRT modalities. So if you have a patient who has a high risk of bleeding, that you think is going to bleed, or you have a patient who's going for surgery and you don't want the patient to bleed post-surgery, then citrate would be your choice of anticoagulant. If you have heparin-induced thrombocytopenia, if you want to prolong the circuit lifespan, or if there is reduced concentration of antithrombin 3. Now, there are contraindications to citrate use also. It's not advised to use it in liver failure because citrate is metabolized by the liver. And in patients with liver failure, the citrate will not be eliminated and will have a lot of severe acidosis. At the same time, if you have paracetamol overdose or metformin toxicity, metformin is a relative contraindication because metformin causes lactic acidosis. At the same time, it reduces the procoagulant factors. And because of that, it predisposes the patient to bleeding. So these are relative contraindications that you must discuss with your patient. Now, requirements. Why I actually put this up, requirement, because like I said, it was a journey doing citrate. We learned through our mistakes. And we were using at one point a dialysate that contained calcium. And we just couldn't understand why we were still clotting. Only later to realize that you really need zero cal. We actually did not know that before. So the dialysate has to be zero calcium containing. So you find that some of these things you actually need to think through before you start prescribing citrate anticoagulation. Now, in short, this is the circuit whereby this is your arterial line. This is where the blood is coming from the patient. And this is where you infuse the citrate solution. The citrate is going to bind the calcium. So by the time it doesn't clot here. And by the time it comes out from here, this is where you're going to replace the calcium to the patient. So this is a simplified version of it. And this is now the version where it's much more complicated. So some of the things I want you to note, and some of the things that we actually as a unit had problems, is identifying where do you get your systemic calcium and where do you get your filter calcium sample from. It might seem easy, but those are the challenges we faced. So the systemic calcium is collected from the arterial side, from the red port, because this is where the blood is coming out. So it's actually indicative of what the patient's ionized calcium is in the blood. After the citrate is infused here, the calcium is going to be bound, and post-filter, this is the ionized calcium, and it's called the post-filter ionized calcium, and you have to get the sample from here. This is because when we were developing this protocol, and it was very hard every time, is it the red port? Is it the blue port? Is it the red port? Is it the blue port? So you have to understand why we are taking from here and why we are taking from there. So that's what I really wanted you to know from this slide. Now, there's a lot of treatment monitoring required, and that is why citrate is a journey, because you must understand why you are monitoring. It's not just for you to just start. So remember, the calcium is going to be bound by the citrate, and because of that, the patient is at a risk of hypocalcemia. However, if the calcium is, the citrate dose is very little, and you're infusing higher calcium replacement, then the patient is at a risk of hypercalcemia. So you need to keep on monitoring the patient ionized calcium. And remember, that is from the arterial point, and you want your target to be 1 to 1.3. Then you need to monitor the filter ionized calcium, and that is after the citrate has bound the calcium, and your target there is 0.25 to 0.5. Now, this is from the Nairobi Hospital protocol guidelines. So it has been, we have taken it there. We have actually from the citrate protocol at the Nairobi Hospital. And what you want your patient to be is within this, that your filter ionized calcium is less than between 0.25 to 0.5, and your patient ionized calcium, the systemic one, is between 1 to 1.3. For example, let's say if your patient's filtered ionized calcium is more than 0.5, that means that the citrate dose is less. So you will need to increase your citrate. If your patient's filtered ionized calcium is less than 0.25, it means you're binding too much calcium and you need to reduce your citrate dose. If your systemic calcium is low, then your calcium supplementation is less. And if your systemic calcium is high, then you need to decrease your calcium replacement. So it's very easy to do it like that, but all these numbers can be quite confusing at any one time. Luckily for us, there are some machines where you just input your ionized calcium and it will calculate for you your citrate dose. Now, you also have to look at the total calcium, and then you have to do the ratio of the total calcium divided by the patient ionized calcium. And it has to be less than 2.5 at any given time. Should it go above 2.5, then you need to stop the dialysis, wait a bit, and restart afterwards. Or you could try and eliminate more citrate by increasing the dialysate flow. You could reduce the blood pump speed, and you stop using the citrate and use an alternative. Now, because this is citrate, there's a lot of electrolyte imbalance that you have to look out for. There's the hypocalcemia, there's the hypercalcemia, there's the hyponatremia. So those are and hypomagnesemia. Those are the electrolytes you have to watch out for. Not only that, you have a risk of developing acid-base disturbances. Remember, citrate is metabolized by the liver. When it's metabolized by the liver, you can form metabolic alkalosis because it's metabolized to bicarbonate. However, if your liver is not functioning well, or you have too much citrate that your liver is unable to metabolize it, then you will find that the citrate remains within the body and causes a metabolic acidosis. So your acid-base status is very important. There are pros and cons to all of this. And the pros of citrate anticoagulation is that it's not systemic. There's no problem with heparin-induced thrombocytopenia. It has a longer circuit life. It can save your patient a lot of money. But the cons is that it can be complicated. It needs all of you to understand very well before you start. And all of you means your nurses, your ICU doctor, you yourself as the nephrologist, and everyone around. It also needs your lab to understand why you're doing all this. The availability of items can be a problem. Like currently in Mombasa, we don't have zero calcium replacement fluid, so dialysate fluid. So that can be a problem. So you have to make sure you have everything before you start. Close monitoring is required, and the cost because of the repeated test. But if you look at the circuit life versus the cost of the repeated test, maybe it would be equal. And it's not a 1 month journey. No, never think that you can prescribe citrate and just go away. It's a whole teamwork. So always remember, everyone needs to understand it, be very comfortable with this before you start it. This is the protocol done by the Nairobi Hospital. And I believe it should be available. Dr. Kioma can tell you, since he's the head of ICU and he's coming next to speak. So this is a protocol formed, and I'd like you to just have a look at this. The first name is a nurse name. It is a nurse who took the initiative and who really propagated for this. So don't think that it is a doctor's journey. It is a whole teamwork journey. Thank you very much.